Hello students, welcome to MOOC's program on drugs acting on blood. So, this is part of unit 2. We have already covered hematinics, coagulants and anticoagulants. Next is fibrinolytics, antifibrinolytics and antiplatelets drug. Myself Gitika Mehta, assistant professor in pharmacology at Rajkumar Goyal Institute of Technology, Pharmacy, Ghaziabad. So, first we will start with fibrinolytics. As it is clear, lysis of fibrin. In previous lecture, we have seen that how clotting occur and how fibrin threads are formed. So, this fibrin which is clot. So, fibrinolytics means lysis of fibrin threads, that is lysis of clots. So, fibrinolytics are the drugs which cause dissolution of clot. So, these are the drugs that are used to lyse the thrombi or clot by activating natural fibrinolytic system. Fibrinolytics, they recanalize occluded blood vessels, mainly coronary arteries, that is they are used to maintain the patency of occluded blood vessels. So, we need to understand mechanism of action. So, whenever there is damage to vascular endothelium, there is a complex interaction occur between platelets, vascular endothelium and clotting factors. So, to stop bleeding, there is the formation of clot occur. Now, fibrinolytics, they dissolve clot. So, fibrinolytics, what does happen? This fibrin insoluble is converted into fibrin degraded products. Fibrin insoluble is converted into fibrin degraded products by the action of plasmin. This plasmin gets activated by its precursor plasminogen. It gets activated by its precursor plasminogen. So, fibrinolytic drugs, they dissolve this clot. Fibrin is a clot and thus they dissolve clot. Fibrinolytics dissolve clot. How do they dissolve clot? Because fibrinolytic drugs converts fibrin into fibrin fragments, and these fibrin fragments are fibrin degraded products. This is brought about by the plasmin, and this plasmin gets activated by its precursor plasminogen. Now, there are the number of intrinsic factors that are present inside our body. These are factor 12A, kallikrein and tissue plasminogen activator. This tissue plasminogen activator is produced from vascular endothelium whenever there is occlusion in the blood vessel. Whenever there is occlusion in blood vessel, this tissue plasminogen gets activated. This further causes the conversion of plasminogen into plasmin. Now, this plasminogen exists in three forms. Either it present in the bound form with the fibrin, or it is present in the free form, in circulation. Plasminogen is present in bound form with fibrin, or it is present in the free form in the circulation. This tissue plasminogen activator, selectively binds with plasminogen that is bound to fibrin. This tissue plasminogen activator selectively activates plasminogen that is bound to fibrin. It does not affect any does not affect plasminogen, that is in the free form. This tissue plasminogen activator selectively activates plasminogen bound fibrin, and thus this plasminogen will convert into plasmin, and this plasmin will convert fibrin insoluble, that is clot, to fibrin degraded product, thus it will dissolve clot. So, these are the fibrinolytic drugs: streptokinase, urokinase, alteplase and tenecteplase, that we give from the outside. So, these drugs are the fibrinolytics that activates the natural fibrinolytic system. This is the natural fibrinolytic system that is present inside our body, which dissolve the clot, and these drugs we give from the outsides. What does they do? They activate natural fibrinolytic system with the same mechanism. So, this is the our drug fibrinolytics, and these are the inhibitors of same mechanism. They are known as antifibrinolytics. We will also cover this further. Antifibrinolytics, these are the inhibitors. So, this will inhibit the conversion of plasminogen into plasmin. This will inhibit conversion of plasminogen into plasmin, and thus clot will not be able to dissolve. Clot will not be able to dissolve in the presence of these antifibrinolytics, that is EACA and tranexamic acid. Epsilon caproic acid and tranexamic acid, these are the antifibrinolytic acid. These drugs, they stabilizes clot. They stabilizes clot. So, this diagram shows mechanism of action of fibrinolytics as well as antifibrinolytics. If it is clear, then you can easily understand their action. So, going further, fibrinolytics, they are also known as thrombolytics. Venous thrombi, they are lysed more easily than arterial. They have little effect on the thrombi, more of 3 days old, more than 3 days old. Plasminogen, this I have already told that plasminogen circulates in plasma as well as remain bound to the fibrin, and this TPA, tissue plasminogen activator, selectively activates fibrin bound plasminogen within the thrombus. So, important fibrinolytics are streptokinase, urokinase, alteplase, retiplase and tenecteplase. So, first in this is streptokinase. So, streptokinase is a protein that is obtained from beta hemolytic streptococci group C. It is non-fibrin specific. What does it mean non-fibrin specific? That it binds to both bound form of the plasminogen and the free form of the plasminogen. So, it is non-fibrin specific, that is activates both circulating as well as the fibrin bound plasminogen. So, it may lead to the bleeding or hemorrhage. One other disadvantage with streptokinase is development of anti-streptococcal antibodies. Anti-streptococcal antibodies. If the patient has a history of streptococcal infection, if the patient has a history of streptococcal infection, then he must be having anti-streptococcal antibodies in his blood. So, due to presence of this anti-streptococcal antibodies, if we give the streptokinase, then this antibodies will inactivate large amount of streptokinase. So, anti-streptococcal antibodies due to past streptococcal infection will inactivate large amount of streptokinase. So, in this case we need to give initially loading dose of streptokinase, then we will give maintenance dose. Okay. And if it will not be effective, streptokinase after administration, it effect will last for 4 to 5 days only. Effect of streptokinase will last for 4 to 5 days only, because after 4 to 5 days anti-streptococcal antibodies will develop. Even in the fresh case, when there is no infection, then anti-streptococcal antibodies will also develop after 4 to 5 days. So, it will not be effective after that. It also produces allergic reaction. Adverse effects are fever, hypotension and arrhythmia. Other fibrinolytics are urokinase. It is an enzyme that is isolated from human urine. It is commercially prepared from cultured human kidney cells. Urokinase activates plasminogen directly and has a plasma half life of 10 to 15 minutes, but it is non-antigenic. So, this is the disadvantage. The advantage is it is non-antigenic, it does not produce allergic reaction, it is neither it is destroyed by anti-streptococcal antibodies, but it is also not fibrin selective. It is also not fibrin selective like streptokinase. Next in importance is altiplase, that is recombinant tissue plasminogen activator. So, tissue plasminogen activator that is present intrinsic to the body, this altiplase is derived from the recombinant DNA technology. It is specific for fibrin bound plasminogen. This I have already told that tissue plasminogen activator selectively is specific for fibrin bound plasminogen. It is non-antigenic, does not produce allergic reaction, it is not destroyed by antibodies. So, these are the advantages. It is rapidly acting drug, shorter half life and given by slow IV infusion. Moreover, it is more potent. It causes mild adverse effect like nausea, hypotension, fever may occur, but it is expensive. So, this what next is retaplase and tenecteplase. These are the recombinant mutant variant of tissue plasminogen activator, resistant to inhibition by plasma activator inhibitor, longer duration of action, injected intravenously as a single bolus dose, tenecteplase, similar to tissue plasminogen activator in efficacy and toxicity. Contraindication to thrombolytic therapy. Fibrinolytic dissolves the clot. Fibrinolytics क्या करते हैं? They dissolve the clot. So, they should not be given when we need to stop the bleeding in the fresh cases of the injury, like they should not, they are contraindicated in intracranial hemorrhage, ischemic stroke in past 3 months, head injury in past 3 months, active bleeding disorders, peptic ulcer, esophageal varices, recent surgery or tooth extraction. So, wherever we need to stabilize the clot, we should not give thrombolytic therapy. Fibrinolytics are also known as thrombolytics. So, where do we use? So, we use fibrinolytics in acute myocardial infarction. They are given immediately. They reduce the mortality rate if they are used within 6 to 12 hours of the attack. Otherwise, it may lead to the stroke, that is brain hemorrhage. So, deep vein thrombosis, it maintains the patency of blood vessel, pulmonary embolism to dissolve the clot, acute ischemic stroke. So, wherever we need to dissolve the clot, already formed clot, there we can give fibrinolytics. to dissolve the already formed clot to maintain the patency of the blood vessel in case of deep vein thrombosis, pulmonary embolism, in case of acute ischemic stroke, in case of acute myocardial infarction, we can give the thrombolytics to dissolve the clot. Aspirin along with the fibrinolytics, they reduce the thromboembolic episodes and thus reduces the infarct size. So, they reduce risk of stroke. So, this was all about fibrinolytics. Next is antifibrinolytics. Antifibrinolytics, as I told you in the earlier flow diagram, they are exactly opposite to the fibrinolytics. These stabilizes clot. These stabilizes clot. So, antifibrinolytics, these are the drugs that inhibit fibrinolysis. They block the binding of plasminogen to fibrin and thus inhibit the dissolution of clot. Thus, inhibit the dissolution of clot. Example are epsilon aminocaproic acid and tranexamic acid. Epsilon aminocaproic acid and tranexamic acid. Mechanism of action: antifibrinolytics, these bind with the plasminogen and prevents the plasminogen activation and inhibit fibrinolysis fibrinolysis. Thus, this stabilizes clot. So, antifibrinolytics, they bind with the plasminogen, prevents plasminogen activation and inhibit fibrinolysis and stabilizes clot. So, first in this is epsilon aminocaproic acid. Epsilon aminocaproic acid. It is analog of amino acid lysine. It combined with lysine binding site on plasminogen and thus block plasminogen activation and plasmin and is not able to bind and lyse the fibrin. So, clot is stabilized in this. How clot is stabilized? Because it combines with plasminogen, block the plasminogen activation and plasmin is not able to bind and lyse the fibrin. So, lysis of fibrin will not occur. So, clot will be stabilized. Adverse effects are skin rashes, nausea, rapid intravascular injection results in the hypotension and bradycardia. Contraindications are hematuria, that is blood in urine. So, risk of the uterine obstruction occur due to the unlysed clot and also intravascular coagulation. We cannot use in such situation in the hematuria and the intravascular coagulation. Next is tranexamic acid. Tranexamic acid is analog of epsilon aminocaproic acid. It is more potent and longer acting. It is given orally, intravenously or topically. Aprotinin is a protein that is obtained from the bovine lung. It is a protease inhibitor, inhibit plasmin, kallikrein and trypsin. Now, uses of antifibrinolytic drugs. So, as they oppose the action of fibrinolytics, so they are used to counteract the effect of fibrinolytics. They are used to control bleeding, like during the tooth extraction, in hemophiliacs, in trauma, in prostatectomy, in cardiac surgery, during the cardiac surgery, in postpartum hemorrhage, in menorrhagia and epistaxis. Epistaxis is bleeding from nose postpartum hemorrhage, that is bleeding after the childbirth. So, fibrinolytics opposes the action of antifibrinolytics opposes the action of fibrinolytics to control, they are used to control bleeding. Next is antiplatelet drugs, which are very important. So, antiplatelet drugs, these are the drugs which inhibit platelet aggregation. These are the drugs which inhibit platelet aggregation. As we have already studied that whenever there is a damage to blood vessel, whenever there is damage to blood vessel, there is a complex interaction between vascular endothelium, platelets and coagulation factors and clotting factors. So, first there is a occur vasoconstriction, first occur vasoconstriction, and then platelet plug formation, platelet activation, platelet adhesion, and then there is the formation of the fibrin strands to stop the bleeding. So, in healthy and normal vasculature, from the vascular endothelium, nitric oxide and prostacyclin is released. This nitric oxide and prostacyclin inhibits platelet aggregation in the circulation, so that unnecessary clot is not formed in the circulation, while thromboxanes, they promote platelet aggregation. So, whenever there is injury, platelet plug formation occur and this platelet plug will form the clot and they will stop the bleeding. So, antiplatelet drugs, these are the drugs which inhibit platelet aggregation. They are useful in the prophylaxis of thromboembolic disorders. The principal function of platelet is to prevent bleeding by thrombus formation. Function of platelet is to prevent bleeding by thrombus formation, and antiplatelet will inhibit this platelet aggregation. Classification: prostaglandin synthase inhibitors, low dose aspirin, phosphodiesterase inhibitor, dipyridamole, ADP antagonist, ticlopidin, clopidogrel, GP2B3A receptor antagonist, abceximab, aptifibrate, tirofiban, others, prostacyclin, etc. So, through this diagram we can understand mechanism of all antiplatelet drugs. So, as we know, in the platelet plug formation there are the 3 steps. Number 1, platelet adhesion, platelet activation and platelet aggregation. So, there are 3 steps involved in the platelet plug formation, that is platelet adhesion, activation and aggregation. So, whenever there is an injury to the blood vessels, platelet adhere to the injured blood vessel and that results in the platelet activation and then results in the generation of arachidonic acid. Generation of arachidonic acid. This arachidonic acid will first, it will release the ADP. It will first release the ADP, which is responsible for direct platelet aggregation. Direct platelet aggregation. And second is this arachidonic in the presence of COX. This arachidonic in the presence of cyclooxygenase will convert into the PGG2 and PGH2. These are the unstable prostaglandins. PGG2 and PGH2, these are the unstable prostaglandin which is further converts into thromboxane, and this thromboxane is responsible for the platelet aggregation. So, thromboxane receptors are present on the platelet surface. This thromboxane receptors will activate platelets, they will activate platelets and thus this fibrinogen and von Willebrand factors, they will serve to cross link the platelets. They will serve to cross link the platelets via the GP2B3A receptors. So, this will result in the platelet aggregation and thus platelet plug will form. So, once again I will repeat this, that platelet plug formation involve three steps: platelet adhesion, activation and aggregation. At the site of the injury, platelets adhesion occur, platelet activation occur by the generation of arachidonic acid. Arachidonic acid, first they will cause the release of ADP. ADP is directly responsible for platelet aggregation. Secondly, in the presence of COX, arachidonic acid will convert into the PGG2 and PGH2 which are unstable prostaglandin, which will further convert into the thromboxane 3xA2. Thromboxane receptors are present on the platelets. These thromboxane will further activate the platelets and cause their aggregation. Kaise? They will stimulate this GP2B3A receptor and then fibrinogen and von Willebrand factor will bind to this GP2B3A complex and will cause platelet aggregation at the site of injury and thus platelet plug will form. In this diagram only we will understand the mechanism of various drugs. Aspirin, which is COX inhibitor, irreversible COX inhibitor. So, it will inhibit the generation of thromboxane. So, thromboxane will not be formed. So, there will be no platelet aggregation. This is first low dose of aspirin. At high dose, aspirin also inhibit prostacyclin. Second is ADP receptor antagonist. This is purinergic receptor, ticlopidine, clopidogrel, prasugrel and ticagrelol. These block these receptors, ADP receptor, and thus they inhibit platelet aggregation. Third is abceximab, eptifibatide. These are the GP2B3A receptor antagonists. They will block this receptor and thus fibrinogen and von Willebrand factor will not be able to combine with this receptor and will prevent the thus platelet aggregation will not occur. So, arterial thrombosis is most common cause of acute myocardial infarction, ischemic stroke and limb gangrene. Deep vein thrombosis leads to pulmonary embolism. Here I will tell you what is thrombus. Thrombus is formation of unwanted clot. Thrombus is formation of unwanted clot, and this formation of unwanted clot when blocks the arteries is known as thrombosis, and this thrombosis is very risky, it is life threatening, it may lead to myocardial infarction, it may lead to the ischemic stroke, it may, and if this thrombus get dislodged and then it can float in the blood, then it is known as embolus, and that embolus may block any of the major artery. So, then it is cause pulmonary embolism. So, antiplatelet agents, they are used to treat arterial thrombosis along with the anticoagulants and with the fibrinolytic agents. So, first is aspirin, which is thromboxane synthesis inhibitor. Mechanism of action: aspirin irreversibly acetylates and inhibits the enzyme COX. We have already shown this in the diagram. So, platelets cannot synthesize fresh enzyme. So, antiplatelet action lasts for 5 to 7 days, that is lifespan of platelets. Daily aspirin dose is 75 to 100 mg. We use low dose of the aspirin for its antiplatelet action, because at high dose aspirin also inhibit prostacyclin, and this prostacyclin is inhibitor of platelet aggregation. So, we use low dose of the aspirin for its antiplatelet action. At low dose it irreversibly inhibit COX. Next is dipyridamole, which is phosphodiesterase inhibitor. It interferes with platelet function by increasing platelet cyclic AMP level and increases the prostacyclin level. So, dipyridamole increases prostacyclin level, which inhibits platelet aggregation. It is used along with the aspirin and warfarin for the prophylaxis of thromboembolic in patient with prosthetic heart valve diseases. It can be used in patient with transient ischemic attack or stroke. Next is ADP antagonist, clopidogrel, prasugrel, ticlopidine. So, these are the products converts into the active metabolite and block the ADP receptors, and these ADP receptors are purinergic receptor. So, block these receptors and thus prevent the activation of platelets and inhibit platelet aggregation. Clopidogrel and ticlopidine, they have similar mechanism of action. So, they are synergistic action with aspirin in preventing ischemic episodes. So, they have the same mechanism, they block the ADP receptors and inhibit platelet aggregation. Last in this is GP2B3A receptor antagonist. These are potent platelet aggregation inhibitor. GP2B3A is receptor on the platelet surface. These are the receptor on the platelet surface, and to this receptor fibrinogen and von Willebrand factor binds, and thus blockage of these receptor, blockage of GP2B3A receptors by these drug abceximab, eptifibatide and tirofiban, blockage of these receptor by these drugs will prevent the binding of fibrinogen and von Willebrand factor to the GP2B3A receptor, and thus it will block the aggregation induced by all platelet agonists. Abceximab is a monoclonal antibody against these receptors. They are given along with the aspirin and heparin during percutaneous intervention. It has markedly reduced the incidence of stenosis, subsequent myocardial ischemia and death. So, this is the summary of antiplatelet drugs, how aspirin inhibit COX, ADP antagonist and GP2B3A receptor antagonist. So, last in this is uses antiplatelet drugs. They are used in coronary artery diseases, coronary angioplasty, stents, bypass implants, acute coronary syndrome, cerebrovascular diseases, prosthetic heart valve, venous thromboembolism, peripheral vascular diseases. So, in all these conditions, it is used to maintain the patency of the arteries, to maintain the patency of the blood vessels. So, that was all about antiplatelet drugs, fibrinolytics and anti-fibrinolytics. Thank you.